I'd like to share the results of a new physician survey that looks at physician perceptions and alignment models. My name is John Cherf. I'm the Chief Medical Officer of Lumere and also a practicing orthopedic surgeon in Chicago. As we move into a value-based healthcare economy, we recognize cost and quality are paramount. Physicians control about 75 to 85% of decisions as they relate to cost and quality. When we look at a hospital or health system cost structure, about 60% is labor and 40% is non-labor. And key areas of that cost, particularly as it relates to physician preference items, are devices, which are anywhere from 9 to 10% typically, and drugs, prescription drugs, at about 70% of a health system cost. Historically, hospitals and health systems have employed physicians to gain better alignment, to better be prepared in a value-based economy, optimizing cost and quality. Lumere conducted a second physician survey this year in 2018 that looks at physician perception and practices. We're really looking at what changes physician behavior and how that's related to alignment models. And we're really looking at the impact on utilization and cost of devices and drugs. We surveyed 276 physicians, and these physicians were in a variety of different alignment models. We compartmentalized the alignment models into three groups or three cohorts. The first cohort is no alignment. That might be a typical private practitioner who may work at a variety of hospitals. The second cohort are physicians who are involved in some type of new payment model, such as perhaps a bundle payment or population health, a co-management agreement, or maybe a bundle payment. In the third cohort, which is the more mature alignment model, were those physicians in an employment model. We asked these 276 physicians 19 questions, and those questions really related to cost, quality, outcomes, physician preference items, what changes behavior, and what information is meaningful. The goal is really to advance physician decision-making to reduce clinical variation, particularly as it relates to drugs and devices. When we look at our findings, there are two major takeaways. One is that physicians that have some experience looking at meaningful data use that data effectively moving forward to make decisions, particularly as it relates to drugs and devices. This suggests that there's a learning curve, that physicians can gain knowledge, and that knowledge can be applied in the future, which I think is very beneficial for a value-based healthcare system. And number two, that employment alignment doesn't necessarily guarantee optimal physician decision-making and behavior. In the next three slides, I'd like to share with you some of the data from this survey. On this bar chart, we looked at the surgical specialists and tried to get an idea of what influences their decision-making. So the question asked was, does device cost and how does device cost and hospital physician preference impact a surgical specialist who might change his prescribing behaviors, perhaps change a vendor in devices he uses. We have three groups of bar charts at the bottom of the slide. On the left are those physicians in the no alignment model. Again, that would be the private practitioner. In the middle are the physicians that have some type of an alternative payment model, ACO or bundle payment or co-management. In the cohort on the right are the employed. So some of the interesting findings I see in this slide are, the question is, if you could get good data that would lower the device cost and the hospital had all the savings, we look at the blue bars. And what we find is the no alignment group is really willing to participate in that situation, even more so than the employed on the right. When we look at the black bars, we're looking at if we could use information, reliable information, good evidence, to lower device cost, and there would be shared savings. The interest was really greater in that middle cohort, the ACO, population health, bundle payment. No big surprise there, as those payment models are designed that the stakeholders take risk, try to reduce cost, and share the savings. And then lastly, when we look at the green bars, was if the data just followed an institutional preference. And paradoxically, the no alignment physicians were much more influenced by data than, say, even the employment model, when we see 40% versus 33%. On our next slide, we looked at committee experience and how this might influence physician behavior on cost. In this example, we're using committee experience as a proxy of education. When we see the two groups of bar charts at the bottom of the slide, on the left are those physicians with no experience in either a pharmacy and therapeutics committee or maybe a device or technology committee, and on the right, those with experience. So the question is, would cost data have an influence on your behavior? And what we see is the bars on the right are greater than the bars on the left, meaning physicians who've had some experience with cost data are more likely to use that data on future decision making. Again, this suggests that physicians can be educated, i.e. through these committees, and that can be beneficial to help change behavior for physicians moving forward. And in our third slide, we're looking at physicians who've had experience with variation reduction. So specifically, we have two bar charts at the bottom of the slide, and on the left are those with no experience, and on the right are those with experience. And the variation type we looked at were general practice variation, which are the blue bars, device selection variation, the black bars, and drug selection variation, the green bars. And I think, so in summary on this last slide, physicians who've had some variation reduction experience in the past are more likely to use that knowledge to make appropriate decisions moving forward in terms of optimizing cost and quality. In summary, we've shared some of the findings of Lumere's Physician Perception and Practices Survey. It begs the question, what is your organization doing to provide reliable data to change physician behavior as it relates to cost and quality? My personal experience has been to be very open, transparent, provide meaningful, unbiased data in a repetitive fashion that physicians are able to understand and digest, and to open an honest educational discussion to optimize cost and quality. I hope you found this overview helpful. Thank you. My name is John Cherf, and I'm the Chief Medical Officer of Lumere.